Welcome back, everybody. Today we're going to talk about the hand, so I encourage you to open your PowerPoint as usual, title hand, and follow my lecture with your PowerPoint. Take necessary notes, of course, on as needed basis. Always compare this information to your book, and you're going to be okay for your tests. All right, let's go to the next slide. Which says bones of the hand, and we have those 8 carpal bones. We already mentioned, of course, the 8 carpal bones are part of the wrist, not hand itself. But the hand itself consists of metacarpals and phalanges, and 4 of your digits have proximal, middle, and distal phalange, when thumb has only 2. Okay, it's a little bit different than those 4. Okay, so let's talk about joints. So each finger has 2 interphalangeal joints, which are going to be called proximal interphalangeal joint and distal interphalangeal joints, or for short PIP and DIP. The articulation between metacarpals and the proximal phalanges are called the metacarpophalangeals, or for short MCP. Okay, so again, so this is your hand, the knuckles, those are going to be your MCPs, or metacarpophalangeal joints. Right here you have proximal interphalangeal joints, or PIPs, and DIPs as a distal interphalangeal joints. The articulation between the proximal end of the metacarpals and the distal row of the carpal bones are called CMC joints, or carpo-metacarpal joints. Carpo-metacarpal joints. So again, those are your carpal bones. So we are right here. Carpo-metacarpal joints. Those are metacarpals. Those are your carpals. So carpo-metacarpal joint right here. Okay, part of the hand as well. Okay, the thumb. Let's talk about the thumb. We said just now it's a little bit different, right? So thumb has an exception. It has only IP's joints. There is no PIP and no DIP joint. There is only one. So we're gonna refer it to the IP. That's it. Only one. No proximal or distal. Just one. Okay, so let's go to the next slide. And here we are. You can find, of course, all of those PIPs, DIPs, MCPs, CM joints on this representation, graphical representation of the bones of the hand. Okay, let's go to the next slide. Arches of the hand. Okay, so we have primarily, of course, we're going to talk about 3 arches. Is transverse carpal arch, transverse metacarpal arch, and longitudinal arch. Well, they are important because they're going to give us stability but also mobility. So the one arch which is going to be built for stability is transverse carpal arch. Transverse carpal arch is this one right here. Right here. So it's a distal row of carpal bones. The carpal bones are built like in a dome shape, which is a very important. On the left hand side on this particular drawing, you can see the keystone, right? So well, let's take into consideration the buildings. When people didn't discover that or invent the arch, the tallest buildings in the world were Egyptian pyramids, and then of course Maya pyramids, Aztec pyramids. But why pyramid? Well, we didn't understand, we didn't know the concept of the keystone. So the only way the building can be tall is when you start thick or wide and you're building lighter and lighter and lighter on the top. Of course, we're going to end up with a pyramid or pyramid-like structure. Now, Greeks and Romans were the first ones to discover or invent the keystone, and that enabled people from then now on, to build taller and taller building utilizing that arch. The keystone is right in here, and that's arch. Why the keystone is even named keystone, and why it's so important? Because distributes the weight above through that arch, and therefore the buildings became taller and taller. And you can look at the beautiful churches and cathedrals, how some of them are huge and yet they do not collapse. All of that is because of the keystone and arch. Of course, in modern times, in our times, we have very tough materials such as steel and fiberglass and glass, which is light and extremely strong and can withstand the weight, and that's why we can build our very, very tall building and not necessarily utilize the concept of arch. So the transverse carpal arch is built just that way, so clearly indicates that is built for stability rather than for mobility. So let's talk about transverse metacarpal arch. Transverse metacarpal arch is where your knuckles are, right? So now you can clearly see that we can either straight it up or arch it, allowing for our hand to be more functional. And of course, the most mobile arch would be the longitudinal arch, which runs between second and third digit. Those two are representing on that arch. The rest of the hand follows. This is most mobile arch or longitudinal arch between the second and third digit. Okay, let's go to the next slide. And this slide actually shows you pictures of what can we do with the CMC joints, particularly the fourth and fifth CMC joint. Okay, so we know that CMC joints are right here, and the fourth and fifth are going to be, I'm sorry, this side. This camera is misleading me again. This side, those two, right? So make a light fist with me. Make a light fist. Don't squeeze it, very light. And you can see this is nicely arched, but nothing significant happens. But now let's make it very, very strong, very, very strong. And you can clearly see that the fourth and fifth digit drops down. So why this is important? Actually, that enables us to have greater strength for grasping objects. So again, if the CMC joints have arthritis, for example, for us from therapy point of view, we know that the patient will have a difficult time to grasp objects, especially heavier ones. Okay, so let's go to the next slide. Next slide talks about creases of the hand. So when you look at your hand, you have all of those lines. Some of them are deeper, the other ones are very, very fine. Some of them are even hard to find. They are so almost microscopic size. Why they are important? Well, not only to go and get your palm read by psychic and know your future, but most importantly, biologically speaking or biomechanically speaking, they are important because you can't fold your hand any other way than those creases would allow you. You can bend your skin where there is no crease. Okay? And the second very important concept is actual grasping object. Okay, this will create some ability for you to hold on to object and not slip out. Okay, the skin becomes a little bit rough on at least a very small scale, allowing you for firmer grasp of objects of everyday use. Okay, and for the test purposes, I will not ask you for those names. I will not give you a picture and with arrows and asking you which crease is located where. I just want you to understand the concept and the primary biomechanical reasons for them to have them and how do we utilize them in daily life. Okay, let's go to the next slide. Volar and palmar plates. So let me first read what is on actual screen. You can see it. Volar or palmar plates are dense, thick disc of fibrocartilage which helps to strengthen joint and prevent hyperextension. Okay, so again, so those plates are going to be in position in strategic places, right? Why? Because extensors, as we mentioned before, are very strong muscles and they could potentially damage your digits. So we don't want hyperextending of our digits. So those plates, tough fibrocartilage plates will not allow those muscles to go into hyperextension of our digits, therefore, of course, damaging joints and muscles and other structures. And we will talk about annular pulleys in a second, but you can observe those structures on the actual drawing, but we will talk about them shortly. Let's go to the next slide, which actually shows you the annular pulleys. Annular pulleys are very important for the correct workings of our hand. Okay, so let's take a look at it. We have 5 annular pulleys. Annular pulley is a tough connective tissue. Okay, it's built the way that the tendons of the muscles run through it. Remember, if the muscle starts outside your hand, starts in your forearm, and like let's say flexor digitorum profundus ends right here on the distal part of your digits, and how possibly could you be able to do this with muscles which originates here? Of course you wouldn't, because muscle ends here. So naturally hand would go like that. Your digits would flex like this, if not some internal structures guiding that muscles so you can have meaningful movement which looks like this. Flexor digitorum profundus, it's presented on this particular drawing, the picture titled annular pulleys. Okay, so you have 5 of them and they named clearly A1, A2, A3, A4 and 5. Now if one of them or more would break, and that happens, people sometimes get severe arthritis which damages those pulleys, or I've seen it actually, patients who were doing some work in the kitchen and they accidentally slashed them with the knives. So what's going to happen, that people will lose range of motion but also strength. Okay, so let me give you some numbers over here. Okay, so let's look at this picture very closely. Pay attention to the moment arm. You know by now what moment arm is, where to look, right? So the moment arm, we can see that pulleys, when they are intact, the moment arm on this particular picture, in this case, is 0.75 centimeter. Are you with me, guys? 0.75 centimeters on the top picture, or the top portion of the picture when the pulleys are intact. In this position, flexor digitorum profundus would be able to flex the PIP joint all the way, which normally is 115 degrees. But when the pulleys A2 and A3, which you can see the picture below, are broken or ruptured, we can observe that the bowstring, we're gonna call this condition bowstringing of the muscle, and you can clearly see why it looks like a bowstring of the muscle tendon, and the length of the moment arm increased, actually doubled. If you can see, from 0.75 to 1.5 centimeter, so it doubled the moment arm, or the internal moment arm from the joint to the tendon of the muscle, literally doubled, which is not good. We will lose range of motion, but we also lose strength of our grasp. In this case, in this particular hand, when you got internal moment arm intact, 0.075 centimeters, and in that particular case, if A2 and A3 broke or ruptured, then the muscle would produce only 58% of the original strength of the PIP flexion. So you lost almost half of strength just by rupturing those two annular pulleys. So it's very important that they are intact. But of course, we will talk about a little bit about the arthritis. And arthritis, it's very, very common, and especially older people can suffer from rupturing of those annular pulleys. And the hands, when you observe the older people, the hands become very stiff or not as agile. The range of motion is affected, and of course the strength of the grasp is affected as well. Okay, I think that's enough for this. Let's go to the next slide. Motions of the MP joints: flexion and extension, abduction and adduction, and of course that comes with its own plane and axis of rotation. Let's go to the next slide. Motion of the PIP and DIP joints: they can only flex and extend, 1 degree of freedom. The next slide shows you the extrinsic muscles, and again, I will not show you any pictures and ask you for those muscles. I just want you to have overall understanding. And of course, when you work in a hand clinics and you would like to become a hand therapist, then this knowledge will become your bread and butter. The next slide is titled Intrinsics. Again, you have all those muscles placed for you. Let's talk about teniar muscle. Teniar muscle is of this bulk over here of muscles. It's not one muscle, but opponens pollicus, abductor pollicus brevis, adductor pollicus, and flexor pollicus brevis. So it's a really nice thick set of muscles. Okay, teniar muscles. Let's go to the next slide. Hypoteniar muscles. Hypoteniar muscles is this bulk of muscles. It's a little bit smaller, right? But it's also an umbrella name for a set of muscles. It's not a one muscle. It's opponens digiti minimi, abductor digiti minimi, and flexor digiti minimi brevis, and palmaris brevis. Okay, so those are your intrinsics. Let's go to the next slide. And here you got pictures with muscles, with the primary movers of certain motions. So the next slide gives you finger PIP and DIP flexors, and that's it. So let's talk about flexor digitorum superficialis test for that tendon integrity. So just to remind you, we have primarily two digital flexor digitorum superficialis and flexor digitorum profundus. When flexor digitorum superficialis inserts here, and flexor digitorum profundus inserts right here. Okay, so this is a testing for one of those tendons. In this case, digitorum superficialis. Therapist holds all the fingers except one being tested. So you choose between digits, or you measure the one which needs to be measured in real conditions when you're working with real patients. This isolates the flexor digitorum superficialis. If client can flex at PIP joint, then flexor digitorum superficialis tendon is intact. If she can flex it, no problems, right? So let's go to the next slide. Let's test for flexor digitorum profundus. So this time you have to immobilize the whole digit except the distal part. So the patient can do only this. Okay, so again, therapist extends all joints of the client's finger except DIP. Therapist asks client to flex the DIP. If the client can, then of course means the muscle or the muscle tendon is intact and work correctly. Okay, let's go to the next slide. You got finger MP extensors. Again, you can take a look at this slide. Just familiarize yourself where is what. Finger MP flexors and IP extension. And extensor assembly. Okay, let's talk about this because it is important. And if extensor assembly is actually damaged or the tendon of the muscle is ruptured, it can cause a certain condition which we're gonna call boutonniere, and it's very common with rheumatoid arthritis. So you probably have seen it by now 100 times of those conditions, but nevertheless, let's talk about it. So over the proximal phalanx, the extensor tendon from extensor digitorum divides into a central band and two lateral bands. The central band inserts at the base of the middle phalanx. The two lateral bands rejoin over the middle phalanx and insert at the base of the distal phalanx. Okay, let's see if we can actually make some sense of it. And you can go to the very next slide and kind of put a color on this slide, or just try to follow what I'm saying, but it's not the easiest of the drawings to follow, to be honest with you. Sometimes even I have difficulties where is what, where I'm looking at the particular drawing. But I will try to show you on my digit over here. So over the proximal phalanx, right here, the extensor tendon from extensor digitorum divides into central band and two lateral bands. So right here, this is the central band, and at the same time, it divides right here into two lateral bands. So it goes like this, and then divides itself. Okay. The central band inserts at the base of the middle phalanx. So this central band right here inserts right here, the base of the middle phalanx. The base is right here. The lateral two bands rejoin over the middle phalanx, so they go separately through the middle phalanx, and they rejoin right before the DIP. They cross the DIP and inserts right at the base of the distal phalanx, right here. Okay, so all of this complicated feature allows you to have controlled and nice and smooth digital extension. Okay, let's go to the next slide. Okay, closing hand and opening the hand. So the dotted outline, of course, represent the starting position of the hand. And the arrows represent the working muscle. So the redder the arrow, the more force is produced by that particular muscle. Okay, so the two muscles which are working the hardest, you can see on this picture, on this drawing, flexor digitorum profundus and flexor digitorum superficialis. So those two muscles are gonna be called primary movers. Okay. But two muscles contradict those flexors. And remember from the previous lecture, the previous video, we know that agonist must be contradicted by antagonist, otherwise the movement will become too much hyper movement always, and you wouldn't elicit any functional movement from, and you wouldn't be able to do whatever you need to do. So two muscles contradicting those flexors are extensor carpi radialis brevis and extensor digitorum communis. So they are responsible for slight wrist extension during finger flexion, and that's exactly what we discussed in the last lecture. Okay, so again, the redder the arrows, the more force is produced, and the dotted arrows represent the starting position. Okay, let's go to the next slide. Opening the hand. It's very similar concept, if not the same. We just have to reverse it. So again, the dotted line represents the starting position, the arrows represent the force of muscles, and the redder the arrow, the more force the muscle produce. Okay, so those are just different stages. You got early stage, middle stage, and late stage, but nevertheless those concepts are absolutely the same, and we already practiced this. You can observe those workings of those muscles. Are you when you closing your hand and you opening, closing, opening, closing, opening, closing, opening. All right, so practice on yourself, understand those muscles, how they work, and remember that when agonist is responsible for movement, antagonist is responsible to keep that movement in check, so it becomes useful and meaningful rather than complete flexion of everything or extension of everything, and no really meaningful movement would be possible. Okay, let's go to the next slide. And muscles again, finger abductors, dorsal introssein, abductor digiti minimi, just for your own knowledge, just to have that mental map of what we are talking about. The next slide, finger adductors, and the next slide, it's called relationship of abduction and adduction to flexion and extension at the MP joint. So I'm gonna read that slide with you, and then we can do that together. Okay, so when MP joints are extended, the collateral ligaments are slack and allowed for abduction and adduction of the finger. When the MP joints are flexed, the collateral ligaments become taut and prevent abduction and adduction. Okay, so if you are quote-unquote normal or stereotypical, that's how it should work. Now, some of you might have more lax joints than the others. That's not necessarily a good thing, but don't freak out. It doesn't mean that you are sick or you have some type of disorder. It just means that your joint have more movement or flexibility that it should, so you perhaps need to start exercising or to strengthen the muscle. You can strengthen really the ligaments, but you can strengthen the muscle around it for better support. Okay, so let's demonstrate. Let's do it together. So when the digit or MPs are extended, you can do abductions, adduction. I'm gonna show it on one finger actually, no problems, right? But let's go now into full flexion of the same digit, the second digit, and now try to go side to side. I can't move, not even 1 millimeter, but try on yourself and see how it works. All right, let's go to the next slide. Position of the long-term immobilization. Well, this is very important for us because we are responsible for sometimes from production or sometimes for ordering a right splint for the right person. Okay, So in this case, we have phalangeal joint in 60 degrees to 70 degrees of flexion, and PIPs and DIPs are extended. All right, so following surgery after some type of trauma, hand may be temporarily immobilized. Okay, the key word here is temporarily. To promote healing, but connective tissue tend to become stiff and resistant to elongation with time, and you know this very well, that if you don't move it, you lose it, right? And ligaments and tendons and muscles have the natural tendency of contracting if not moved, or in place in the not correct position. So to reduce the likelihood of the tightness within the collateral ligaments and the MCP joint, we splint the hand in that very way presented on this picture. So MCP joints are flexed to about 60 to 70 degrees because this position places the collateral ligaments and extensor muscles in elongated position, and we just practiced this. And you know that in complete flexion, of course, the collateral ligaments becomes very tight, not allowing you for abductions and adductions. So this, and of course, pay attention to wrist. Wrist is also in the functional extension. Okay. So let's go to next slide. And this is just the movement of CMC joints, thumb flexion and extension, also known or sometimes called radial adduction and abduction, and palmar flexion extension, also known or called sometimes palmar adduction and abduction. Okay, this is radial and this is palmar. Okay, let's go to the next slide. Here we are, the thumb movement, you can clearly see, and with explanation, so it's not much I can tell you more than you can actually see on that particular slide. It's titled Thumb Movements, and let's go to the next one. It's actually thumb movement at CMC joint. So this is the anterior view on the thumb movement at the CMC joint. And what can you see? What can we do? Flexion and extension, and again, or radial abduction, adduction. You can actually name it interchangeably. They both are correct descriptions, really. An abduction and adduction, or palmar abduction, adduction, and opposition. Okay, let's go to the next slide. Arthrokinematics of the thumb in the CMC joint. Again, you can see that all those joints work in similar fashion. You got roll and slide in opposite directions. Of course, to prevent that roll off the joint, the simultaneous slide back is needed, and this is how we abduct the thumb in the CMC joint. Okay, let's go to the next slide. And set of muscles again. Thumb radial abductors or extensors, thumb palmar abductor, thumb adductor, opposers, thumb MP and IP flexion, thumb MP and IP extension, and functional position of the hand. Well, functional position of the hand is different now, right? So we have to be aware of that, because we are going to again either construct or order the right, depending where you work. Some places like therapies to make those splints, some order those splints, but nevertheless, in either case, you have to know what you're doing. So functional position splint is used for either resting, a resting splint, or for people who are paralyzed. So I actually created some of those, or produced some of those splints, and but in majority of times I was able to order the right splint. for my CVA patients. So resting is in 20 to 30 degrees of extension and slight ulnar deviation. Fingers in 45 degrees of MCP, 15 degrees of PIP and DIP in comfortable flexion. Thumb is in 45 degrees of abduction, and it's clearly shown on this picture. So this is your functional hand position. Okay. Let's go to the next slide. Okay, intrinsic plus. So in this case, I'm going to read from the slide first. Flexion of the MP to 90 degrees and extension of PIPs and DIPs. It's also known as a rooftop position because clearly you can see kind of reminds you of a roof. Introsei and lumbricals are at their shortest position, and lumbricals and introsei, of course, are responsible for MPs and IPs extension. So you can commonly see this condition of the hand with patients with rheumatoid arthritis. Okay, so the next slide shows you intrinsic minus position. So hyperextension of the MP joints and flexion of the PIP joints, or in other words known also as a claw hand, and clearly it kind of reminds you of that claw, right? So this is paralysis of introsei and lumbrical muscles. It's a paralysis. Okay, what else I would like you to know about that? This particular deformity of the hand is caused not so much by arthritis, but rather by ulnar and medial nerve injuries. Ulnar and medial nerve injuries, they're gonna create, but together, both of those nerves have to be negatively affected by injury. Sorry for that, but my throat is getting very tight over here. Okay, let's go to the next slide. This is just a picture of intrinsic plus and minus positions. The same hand, just demonstrate how it looks like. So again, one is primarily caused by arthritis, the other one by injury to the nerves. Different types of prehensions. Power grip to hold a hammer, precision grip to hold an egg or to hold a ball. So like this would be precision grips. Power key pinch, tip to tip. Let me demonstrate. Power key. So of course I have a keys over here to my office. So this is the position, this is the hold, right? Tip to tip is different than pulp to pulp. Okay. Hook. I'm looking for the camera again. Here we go. Three-jaw chuck. This is to hold the pen. Three-jaw chuck. Okay. And cylindrical grasp, like holding a bottle with water. Okay, let's go to the next slide. We have a lot of problems with hands. We had a lot of movement. It's very mobile. Therefore, we have a lot of injuries to the hand. So we're going to discuss some from the long list, but we will discuss to certain minimum extent, let's call it, intrinsic tightness, ulnar nerve injury, medial nerve injury known as a carpal tunnel syndrome, radial nerve injury, mallet finger, swan neck deformity, boutonniere deformity. Both of them are commonly known as the zigzag deformity, so zigzag is not a separate, it's rather combination of swan neck and boutonniere. De Quervain and Dupuytren's contractures. So let's go through them one by one. Okay, let's do those tests first, right? So Bunnell-Listner test for intrinsic tightness. So MCP joint held in slight extension, and just look at the drawing for explanation. Therapist moves the PIP joint into flexion. If can't be flexed, the intrinsic or joint capsule is tight. Okay, so that's what that means. If you cannot flex it, that the joint itself has a problem. Okay, let's go to the next slide. This is step 2 of the same test. Place MCP joint in a few degrees of flexion to relax the intrinsic muscles. If joint can be flexed now in this position, then it was intrinsic muscle tightness, but not a problem with the joint. All right, so to clarify this, you're looking either for intrinsic muscle tightness or something wrong, that unnatural tightness in the joint capsule itself. This is the way to do it. And step 3, when MCP joint placed in flexion and the therapist still can't flex PIP, then is the joint capsule tightness. All right, so let's go to the next slide. Muscle innervated by the ulnar nerve, and you got all set of muscles. All of them are innervated by ulnar nerve. So if you know what the primary responsibility of that muscle is, and you know that the patient had ulnar nerve damage or trauma to ulnar nerve, you know which muscle is not going to do what type of job. Okay, so let's go to the next slide. Ulnar nerve injury can cause flexion deformity of the 4th and 5th digit or finger due to paralysis of the muscles, and the muscles are lumbricals. Atrophy of the hypotenular eminence. Hypotenular eminence, we talk about those muscles. It's a group of muscles. Atrophy meaning dying out, thinning. Atrophy of the introceae, atrophy of the thumb web space. So this web space right here become very thin, and you can see it especially in older adults. It's almost non-existing. You can see just a skin, but you can also almost see through it, right? No muscles there. Difficulty holding a paper between thumb and the index finger, and partial claw hand, ulnar nerve and medial nerve to do the full claw hand, but partial claw hand if you have only ulnar nerve damage. So let's go to the next slide. And here we are, one of the conditions when the Guyan tunnel syndrome. Of course, the nerves are gonna go through the carpal bones, which they can be trapped or compressed, and this usually happens through some type of trauma to the hand, some type of injury, usually mechanical. So ulnar nerve may become compressed in the Guyan tunnel, which is located between the hook of the hamate and the pisiform. So there is a tight space in the beginning, but if you have add trauma to it, of course those bones can shift and compress the nerve. Let's go to the next slide. Fromen sign, we just talked about it. The person with the ulnar nerve injury have a difficult time to hold that piece of paper. Why? Because we talk about those muscles right here. They are very, very weak. Those muscles are dying out and are incapable of holding piece of paper in this position. Okay, let's go to the next slide. Ulnar nerve injury, like I just mentioned, it's a partial claw hand. So the hand is not gonna go fully into claw hand, but rather the digits which are affected by ulnar nerve are gonna go farther, and those two are gonna be less affected because they are innervated by the median nerve. So when the median and ulnar nerve are affected, then you got the full claw hand. Okay, let's go to the next slide. This slide again just mentioned the muscles which are innervated by the median nerve. So it's a full set of those muscles. So if you know what those muscles are responsible, and if you know that the patient suffered from the median nerve injury, then you know what is going to happen. or at least roughly what can happen. So median nerve injury is unable to oppose thumb, unable to make a complete fist. So of course your grasp, your prehension is going to be greatly affected. Atrophy of the thinner eminence, those bulky muscles, weak wrist flexion and weak pronation of the forearm. Okay, so this is carpal tunnel. We discussed that carpal tunnel already. You got the transfer carpal ligaments. On one side you got it's like the roof, then on the other side, like the floor, you got the carpal bones, and a lot of muscles are going through, nerve supplies, of course by median nerve, blood supply, etc. All of it goes through the carpal tunnel. As you can see, the ulnar nerve does not go to carpal tunnel. You can see it on the left side, right above the transverse carpal ligament is the ulnar nerve. Doesn't go through the carpal tunnel, but it's very close. Okay, let's go to the next slide. Carpal tunnel syndrome, Tinel's sign. Tinel's sign, when therapist taps over the carpal tunnel, the client will feel that electrical sensation, that tingling in the affected digits. So again, you can make two fingers like that and tap fairly strongly, and if you feel that, or your patient feel that shooting kind of electrical stimulation, that means that the nerve is already compromised. Funnels test. Therapist flexes client's wrist manually and holds together for 1 minute. Positive test elicit tingling in thumb, index finger, and middle and lateral half of the ring finger, and is indicative of the carpal tunnel syndrome. So this is another test, another way of testing the carpal tunnel. If your patient is not comfortable or the skin is fragile and you don't want to tap, then this is another way of doing that test. Okay, let's go to the next slide. And another set of muscles. This time those muscles are innervated by the radial nerve. And again, the same concept. If you know what those muscles do, and if you know that the radial nerve was damaged, then you can anticipate what the patient can or cannot perform. So radial nerve injuries is a dropped wrist, which looks like this, right? Lack of MP extension, lack of thumb IP extension, lack of thumb abduction, and grip affected due to lack of wrist extension. Of course, we talk about the importance of wrist extension in grasping object. 35 degrees extension and 5 degrees to ulnar deviation. If we don't have this, our grip is significantly affected, negatively affected, and we did this experiment with squeezing an object in our hands. Okay, let's go to the next slide. This is a simple drawing of the dropped wrist with the radial nerve injury. The next slide, mallet finger. Okay, we talk about this extensor assembly and how the tendons of the muscle, the digitorum extensor, how it works, how it divides, and how it joins together and inserts itself into the distal distal phalanx. So the tear of the extensor tendon from the attachment of the distal phalanx can cause the condition called mallet finger, when the tip of the finger just drops because the extensor digitorum doesn't work at this part of the finger. And again, commonly in arthritis, but also of course manually you can damage this through, by accident, cutting yourself with the knife and stuff like that. So let's go to the next slide. Swan neck deformity. Swan neck deformity, you can see many arthritis patients. It's relatively common. So the swan neck deformity is characterized by hyperextension of the PIP joints with flexion at the DIP joints, where the MCP subluxes volarly. So MCPs are going down, right? And of course, rheumatoid arthritis is the main culprit with this deformities, with this hand disease, and it's part of this zigzag deformities. Okay, so let's go to the next slide, which talks about boutonniere deformity, which is also that part of that zigzag deformities. So the central band, remember when we talk about the extensor and how the extensor goes, inserts here and right here, and then divides itself and inserts itself back right here. Well, the central band of the extensor ruptures, and the lateral bands therefore slip to the volar side. So right here it ruptures, and those two bands which should join and insert in right below DIP, they actually free to move, and they will move, and they're gonna slip to the other side of the digit. Well, that's not good, because that is going to produce movements which we don't want. And clearly you can see on this drawing, deformity is a result of the rupture of the central tendon and the tendon slip of the extensor hood, and it causes the deformity, which we're gonna call the boutonniere. All right. So in other words, the DIP joint is consequently, instead of the PIP extension, we can observe PIP flexion, with MCP and DIP extended. So the muscles are all working in the wrong direction, so to speak. And this is called boutonniere deformity, and again is a part of the zigzag deformities. So for the next slide, we have a picture of a hand of a person who really suffers from bad rheumatoid arthritis, and you can see over here that that on one hand the person can have actually both conditions, boutonniere deformity as well as the swan neck deformity, and the hand becomes very weak, the range of motion is greatly affected, the hand is weak, so the prehension, the grasp is very weak as well. Okay, this is the same condition, but the thumb of the thumb. So here you have also presented the arrows. One is long and black, the other one is shorter and red. So remember what I said before, that the redness indicates the amount of work the muscle actually produces. So the flexor pollicus longus is elongated, becomes very taut, it's elongated, and it doesn't work properly. An extensor pollicus longus is kind of bowstringing over here, producing a lot of force, adding to that rheumatism and that problem, and the whole thumb goes into that zigzag deformity, just the same way like other digits can. Okay, let's go to the next slide. The Quervain disease. The Quervain disease is the tenosynovitis, and it can be actually very, very painful. It's inflammation. Tenosynovitis stands for inflammation of the thumb tendons and the radial styloid process. The muscles involved, on the tendons of the muscles involved, is abductor pollicus longus and extensor pollicus brevis. So you can find the radial styloid process right here. It's sticking out like a bony prominence right here, and we will find that during our face-to-face meetings, because it is important for us for the goniometry reasons and manual muscle testing. So the swelling in this area is going to produce tenderness and a lot of pain, therefore affecting your ability to move your entire hand. Okay, let's go to the next slide, which is Finkelstein test. A client makes a fist with the thumb inside, so looks like this, right? Therapy stabilizes forearm and ulnarly deviates the wrist. So again, you stabilize and you ulnarly deviate the wrist, just like that. Positive sign is pain over the abductor pollicus and extensor pollicus brevis. So again, if you have discomfort, that's okay, because I feel discomfort too when I'm going into the extensive ulnar deviation. But if you have a severe pain, that could actually indicate a problem. Okay? So again, I do believe that this is last slide. No, we have another slide, which is Dupuytren contracture, and I don't know if my pronunciation of that is correct. Yours probably is better than mine, but is fibrous contracture of the palmar fascia. So here we have a fascia which goes kind of like in the triangular way. It's a tough connective tissue for protection of our internal features of our hand, and sometimes for idiopathic reasons, sometimes idiopathic means we don't know why, and sometimes injury to this fascia causes this fascia to contract, and usually is to the 5th or 4th digit. That's just the way the biology works. So fibrous contracture of the palmar fascia, and the digit goes like this. Now sometimes our therapy works, ultrasounds, hot packs, massages, exercises. Sometimes it gets so bad, or people neglect to go for therapy or do anything about it, that the surgical release has to be implemented, and then most likely you're going to see those patients post-surgically. And another slide is showing you gangrene. You can't be too squeamish to see those pictures. Gangrene, of course, could be potentially deadly without medical help, and sometimes, of course, causes amputations. I personally had a patient who came with one digit look completely black, just like you see it on the left hand side on the top. So his partial hand was very black, but one of his digits was completely black. And I was a student in hand clinic, and my supervisor asked me to prepare the hot water bath for that patient to clean the debris. The best way to clean this debris is, of course, submerge the water into the hot bubbly water, not too hot, of course, but warm. Let's pull it warm bubbly water to cleanse the area. And we usually left this patient for about half an hour or so, if I remember correctly. And after the treatment, I came back and I asked my patient to lift the hand up and take it off the hot bath. And I was absolutely horrified because he lost that digit. That digit was actually on the bottom of that pool. And I was a student. I freak out, but my CI kind of calmed me down, told me that, you know, that was actually predicted. They knew that this might happen. Unfortunately, happened on my watch, but was absolutely nothing I could do about it. And even the patient freaked out less than I, because the patient was already prepared by his surgeon that this actually most likely will happen. So that was the amputation by bubbly water. Okay, let's go to the next slide. And that's it. There is no next slide. So thank you guys for your attention, and I see you shortly. Bye.